Hello. 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 Good evening, sir. Sir, I cannot hear you. Hello. Hello. Can you hear me, sir? I think he cannot hear me. Is my yeah. Dr. Sujit Jagtap. His mic and video. I can't hear him. I can see him. नहीं ईयरफोन्स नहीं है. He is.
काय चाललंय?
Good evening, sir. Sir, I think Dr. Jagtap cannot hear us because we are at. You are able to hear us, but sir, we are not able to hear. We are not able to hear you. No. Sir, are you using any earpiece, any earphones, or anything like that? No, I can see you talking. That is why I'm responding, but I am actually not able to understand what you're saying. No, I don't think anyone can hear you. So maybe you could try logging out and logging in again. He's logged out.
Hello.
Yes. Good evening, sir.
Yeah, Pramod Krishnan here. Audible here?
Yes, audible and visible also.
Okay.
So would you like to check your presentation?
Okay, let me try that.
Yes. Any videos in your presentation, sir?
No videos.
Okay, all right. You could start sharing your. You can open your PowerPoint presentation first.
Yeah.
So then you can share the screen.
It's there?
Not yet. Yes, now I can see it.
Now?
Yes. In full screen mode, I can see it properly.
Okay. Is there any lag or break in the voice or something?
No, nothing.
All right. So I'll stop sharing.
Yes. So in case if at all there is a lag or breaking of your voice, I will definitely notify you of that. And then at that point of time, maybe we could try stopping your video so that it does not consume much of data.
Agreed. All right. We'll do that.
Yes. Okay.
So we are going to have questions at the end of all the 4 talks, right?
Yes, that's right. After Dr. Jagtap's talk, then we will take up the Q&A.
Okay. This is in a webinar mode or it's not in a webinar mode, no?
It is in a webinar mode, sir.
So they cannot, others cannot speak, only the
faculty can speak.
Okay.
The attendees will not be able to speak. Whatever they want, they can put it up through the Q&A section.
All right. Okay.
No, sir, we still can't hear you. So what I would suggest is where you have your mic in Zoom, you can go into the audio settings and you could check your output and input level.
Okay.
Now we can hear you.
Now you're audible.
Okay.
Yes.
Good. Hi, Pramod. How are you?
I'm fine. What, you're sitting in some palace or something?
Yes. Home palace. Virtual background.
Oh, it's a virtual background. Okay, okay.
Yeah. Yes. Good. So, Vila, I think Dr. Rajesh will also be joined now. So, how is life? COVID or non-COVID?
It's a mix of both. A lot of COVID cases. So we have to see everything now.
Okay. You are in the Manipal Bangalore Hospital, na? Manipal
Yes,
Hospital,
yes, yes.
Bangalore.
Yes.
Okay.
My
Because
wife is in neuropathology NIMHANS, so she keeps telling me that a lot of Sujit samples coming, epilepsy samples.
yes.
Everybody knows Sujit Jagtap there, all the pathologists. And
Because
he's only one who types and sends the request.
because we are now pro forma and our resident is trained to do that.
Perfect. Super here. That's how it should be.
Yes. Kalyan is joining.
Wow, Sujit, clean shave.
Yeah, thank you, madam. अरे आज मास्क नहीं है ना. नहीं तो कळतच नाही काही.
Oh, Sujit is sitting with some awesome background. What is that?
It is a palace.
It's a virtual background. You can see near the chair some signal changes are there.
Yes, at the end.
I don't know. How do we change this background?
Go to the video.
In go to video. I am in video only, no?
No. Videoच्या तिथं जे icon आहे तिथं right click.
Oh, choose virtual background.
Yes.
Sujit has selected palace. Oh my God.
Rajesh sir, good evening.
The mustache is missing, though the palace.
Yes.
He looks
कहाँ
5
बैठे
years
भैया
younger.
सुजीत तो
Huh?
Yes, sir.
सुजीत किधर है? Where are you?
Here only at home.
He's in a palace, sir.
अच्छा बढ़िया घर बनाया रे.
Ah.
हाँ वही देख रहा था. Good man, happy you have built a palace.
Sorry to interrupt. But I would request you, sir, to face the light and sit, because right now there is a lot of darkness on your face and we are unable to see your face properly.
Who, Dr. Rajesh Iyer, is it?
Rajesh.
Yeah, I think that should be better.
Yes,
Yeah,
yes,
now it is good.
definitely,
ठीक
much
है.
better.
Yeah.
Sir, would you like to try your presentation? Would you like to check your presentation?
ठीक है. I'll try mine first. Yeah.
Yes.
Yes.
देखते
You are the
हैं.
senior most.
Okay. हाँ. एक मिनट कहाँ
Sir,
गया?
any videos in your presentation?
Yeah, videos are there.
Okay. So, sir, what I would request you to do is open your PowerPoint and then click on the green button of share screen just once. Setting we need to do before we actually share your screen.
Yeah.
We have to share our screen. No?
Yeah.
Sorry?
After Rajesh sir, you can share.
No, I'm just asking. We have sent them a PDF, no, but we are going to share our PowerPoint, right?
Yes.
Yes.
Oh, you
so
sent
that
the-
PDF is put up on the Fine website and the app.
Okay.
To
Got it.
refer to it later.
Got it.
Oh, you sent the PDF, is it?
Yeah, so I will.
They said no 15 days back to send, so I said.
Uh,
My presentation was complete only now, half an hour ago.
Same
You
here.
see?
Yeah, we can see that.
yes, we can see.
Yeah, I sent it faster than you guys. Some video.
So your internet connection
Let's see if
seems
it
to
is
be
coming.
unstable. Hello.
Maybe I will stabilize it a little bit. Able to see, right?
Yes.
Video is playing?
Playing well.
Okay, all
It
right.
is
Take it
playing,
done.
but it is breaking.
Okay, all right. So let us see. Okay, I think should be okay. Once I open the door, should be okay. Yeah, that should not be a problem because it's on Wi-Fi only. I think should work well.
Yeah. Last time in one of these webinars, what they told me is in the home also, if there are other devices on WhatsApp, on Wi-Fi,
Wi-Fi.
ask them to stop it so this speed increases bandwidth.
That should be disconnected. Yeah, correct.
Yeah.
Yeah. Maybe
So,
I can switch off my video while presenting and then run this. Yeah.
Okay.
Okay, so should be okay.
Hmm.
Okay, if the video doesn't play, we'll describe the video. Not a problem. So I will stop sharing. Yeah.
I'll try now.
Okay.
Pramod,
Yeah.
you want to try?
No, I tried already.
Sauta.
He has tried, he's tested.
Okay, I will try. You can see, no?
Yeah, it is coming. Wait.
Any videos in your presentation?
No. You can see?
Can you go maybe back and forth a couple of slides?
Yeah. I did.
Sure, okay, all right.
Okay.
अरे कोणाचा बॉन्डचा फोटो टाकलाय
Rasmussenचा टाकलाय.
छान टाकला मी एकदम
Okay, so I'm stopping my sharing.
Yes, yes. Dr. Chakta, he
Yes.
has done presentation. He has done multiple presentations rather before.
okay
Only all other unwanted Wi-Fi devices to disconnect and
To keep you all informed, all the videos go live on YouTube. In case if you're showing patient videos, I am assuming that you all have the consent to show the videos. Any information which you're showing in your slides, I'm assuming it is okay to go out in public domain.
Yes.
Unnecessarily
Let us confirm with Dr. Iyer because he is showing a patient video.
Yeah. So I think Wi-Fi should be okay. I think.
Okay, sir. So
Yeah.
another a small query I had is that rather information for you is that this video will go out live on YouTube. I hope it is okay with you and your patient.
Okay, generally we take all consents for video EG, but then
Okay.
hopefully it's nobody on the YouTube. Is it recorded?
Yes, it is recorded and then put up on YouTube.
Well, so in that case, probably you can put it up without the videos. No, when you record and put it up.
So, no, what I mean to say is that it goes live right now. While you're talking, it will already be live on YouTube.
Okay, but is this? I mean, when it goes live, I mean it's okay for people to see it live, but then will it be permanently there in the YouTube?
Yes, sir.
Oh, okay. All right. So probably I might delete one or two videos in that case. Okay. So that which
Yes,
is
sir.
obviously visible, I might delete it off.
Yes, okay.
Doesn't
Okay.
matter. Yeah.
Yes.
So
Okay.
so generally, I think when it's going live, it's not recorded on YouTube, right?
It is recorded, sir. It is recorded on YouTube.
Okay. All right. So I will remove one or two videos. That's fine. No issues.
Yes.
Yeah.
Yes. Yes. Okay. All right.
okay
Okay. We are at 8:28, so we have
yes
2 minutes to go. Should I open the room for all the attendees?
yes we can Pramod, you have shared your no
Yeah, I've tried mine. Yes.
He has
No.
checked.
Yeah.
Okay, so I will share my screen and one small request to all of you. When one speaker is talking, I would request the others to put your video and mic off.
Okay.
Can do it right now, actually.
We have attendees joining in. We are now all audible and visible to the attendees. We are at 8:32. So would you want to wait, or would you like to wait a couple of minutes more?
Yeah, we'll wait 2 more minutes and then we'll start.
Okay, sure.
So, Mansi, shall we start?
Yes, Dr. Krishnan will have to share his
Yes.
screen, and we can.
Yes. Okay. So good evening all. Welcome all for Epilepsy Module 1. The first talk today is Basic Mechanisms of Epilepsy with focus on recent advances by Dr. Pramod Krishnan. He is a consultant neurologist and epileptologist at Manipal Hospital, Bangalore. He has done DM neurology and gold medalist from NIMANS, and then he has done his epilepsy fellowship at Sri Chitra Trivandrum. I will request Dr. Pramod to start his talk.
Thank you, Dr. Sujit, and thank you to FINE for giving me this opportunity to present this topic. So I'm sharing my screen now. Is it visible?
Yes.
Okay, so good evening, everybody. Today I will spend 15 minutes on talking on basic mechanisms of epilepsy. So this is the outline of my presentation. So what is the importance of this topic? We need to know about the etiopathogenesis of epilepsy so that we can predict how seizures happen, the clinical manifestations of seizures, and the electrical features of a particular type of epilepsy. Knowing the mechanism of epilepsy also allows us to target the epileptogenic process with medications. So this will be the main focus of today's talk. Before that, one look at some definitions. Seizure is the clinical manifestation of an abnormal and excessive excitation and synchronization of a population of cortical neurons. And this can be due to many different reasons. Whereas epilepsy means an enduring tendency within the brain to generate recurrent seizures, which are unprovoked or reflex. This is the epilepsy definition from ILAE: two or more unprovoked or reflex seizures occurring more than 24 hours apart, or a single unprovoked or reflex seizure, and a probability of further seizures similar to that after two unprovoked seizures, or diagnosis of an epilepsy syndrome. But what we are going to talk today is epileptogenesis, which is the sequence of events that converts a normal neuronal network into a hyperexcitable network. These are the principal players in epileptogenesis. We have the six-layered cerebral cortex, which contains predominantly the pyramidal cells and the non-pyramidal cells, which are mainly the interneurons. We have the glial cells, mainly the astrocytes, microglia, oligodendrocytes, and ependymal cells. So we'll see the roles of each of these cells in the process. The cortex is six-layered, but some parts of the brain, phylogenetically the older parts, such as the hippocampus, they are three-layered. Now, this is the basic circuit that we will be referring to. This is the dentate gyrus, and what you see in blue color is the granule cell. So we have two types of neurons. One is called the projection or principal neurons. Example are pyramidal cells, granule cells. We have interneurons, which are, example is a basket cell. Now the projection neurons, they project to different distant parts of the brain. They are generally excitatory on the postsynaptic neurons. Whereas interneurons, they are local circuit cells. They influence the activity of nearby neurons. In the diagram, it's represented by the yellow color. So you can see the granule cell projecting to CA3 area of the hippocampus. But there is a process that goes back to the inhibitory interneuron, which in turn inhibits the granule cell. So this is what we call feedback inhibition. These are a list of various causes for seizures and epilepsy, depending on age group. As you can see, the etiology is very varied, from developmental disorders, genetic disorders, trauma, infections, metabolic disorders, cerebrovascular disease, neoplasms, substance abuse. But eventually, all these different mechanisms cause seizures or epilepsy. So we have to see how that happens. If you look at an acute symptomatic or a provoked seizure, it basically reflects a transient change in the balance between inhibition and excitation. So excitation dominates and triggers the seizures. But when we come to the mechanism of epilepsy, it is not that simple. We need to address many other issues. In epilepsy, it's not one seizure. You have a predisposition to recurrent seizures. So you have to explain how seizures occur again and again. And these seizures are not so common. They may happen once or twice a year, maybe once or twice a month. So you need to know why it doesn't happen on other days. And they are unpredictable. And there are many mutations in animal models that do not necessarily show changes in excitation or inhibition. So mechanism of epilepsy is not just about excitation inhibition imbalance. We need to explain the episodic nature of epilepsy and the varied etiology. So we'll just go through all that now. The primary thing is there is increased excitation. The ions that are involved are sodium influx, calcium influx, and the main neurotransmitters are glutamate and aspartate. So increased excitation can happen if there is increased excitatory neurotransmission, or it could be decreased inhibitory neurotransmission. It could be alteration in voltage-gated ion channels, or it can be alteration in intra or extracellular ion concentrations. Sometimes you need multiple synchronous subthreshold excitatory stimuli to have excitation in the postsynaptic neuron by temporal summation. Similar factors are responsible for inhibition. Here it's mainly due to chloride influx, potassium efflux, and the main neurotransmitter is GABA. So there are many more neurotransmitters. These are the main ones. Looking at GABA, it's the major inhibitory neurotransmitter. There are two subtypes relevant to epilepsy, GABA A, GABA B. GABA A is postsynaptic. It causes chloride influx and hyperpolarization. And the agonists like benzodiazepine and barbiturates, they suppress seizures. GABA B is presynaptic autoreceptor, so it can modulate synaptic release. It is associated with second messenger systems. It causes chloride potassium channel opening and a hyperpolarizing current. If you look at glutamate, which is the major excitatory neurotransmitter, it acts through two receptors, inotropic receptors, which enhance fast synaptic transmission, and metabotropic receptors, which participate in slow synaptic transmission. So the three main types of inotropic receptors are NMDA, AMPA, and kainate. They all act through sodium influx. NMDA, in addition, can act through calcium influx. It can cause excitotoxicity and cell death because of excessive calcium influx during excessive stimulation, for example, in status epilepticus. Metabotropic receptors, they act differently. They act through membrane-associated G protein, and the stimulation has different effects. So this is a diagrammatic representation of the inotropic receptor and the metabotropic receptor. You can see the metabotropic receptor is G protein coupled, and it is also connected to the inotropic receptor as well. And this is the GABA receptor showing the chloride channel and the different sites of action of barbiturates, benzodiazepines, and steroids. Now, it's not just about release of neurotransmitters and its action on receptors. The reuptake also matters. So reuptake mechanisms exist on both neurons and also the glial cells, mainly the astrocytes. So there are specific transporters, and any defect in reuptake means prolonged action of these neurotransmitters. And depending on which neurotransmitter is involved, you can have activation or suppression of epileptiform activity. So all this finally boils down to neuronal excitability. This in turn is determined by certain intrinsic cellular factors, and there are some extrinsic factors or extra neuronal factors. The cellular factors are ion channel type, number, and distribution, biochemical modification of the receptors, activation of second messenger systems, and modulation of gene expression. Whereas the extra neuronal factors are changes in the extracellular ion concentration, remodeling of the synapse location or configuration because of afferent input, and modulation of transmitter metabolism or uptake by glial cells. Eventually, the varied etiology they all come down to a final common pathway, which is an episodic shift in the balance between excitation and inhibition. So there's a shift that happens now and then, and these shifts, they are self-reinforcing. So a shift towards excitation promotes more excitation. So this is called activity-dependent disinhibition. So we'll see this in detail now. So there is a state where excitation and inhibition are balanced. There is an episodic shift in this state. This causes increased activity within the epileptic network, and this leads to network instability. This in turn further increases network activity. So this is what we call self-reinforcement. And when it crosses a particular threshold, it results in seizures, and seizures again increase the network activity. So this is a self-sustaining mechanism till cellular exhaustion happens. So it's the same thing in a different way. You can see the various electrical activity within the epileptic network in the top left corner, and then it can summate to a level where it crosses a seizure threshold, resulting in seizures. And this kind of electrical activity, they have a positive feedback mechanism wherein they increase the excitatory activity because they degrade various inhibitory systems present in the network. So this is how the activity can build up, and reach a level where it triggers a seizure. This probably explains the timing of seizures. We have the brain in various states, and we can look at it in a different way. For example, in an autosomal dominant nocturnal frontal lobe epilepsy, the brain state relevant may be the NREM sleep or REM sleep. When the brain shifts to NREM sleep, then these epileptic networks are able to show more excitation, and therefore seizures occur in NREM sleep. Similarly, in catamenial epilepsy, this shift in the balance towards excitation happens during specific stages of the menstrual cycle. So these are the brain shifts, and these are the specific epilepsies that occur at those times. But we must note that every time there is an NREM sleep, you don't get seizures. During every monthly cycle, you don't get a seizure. So there are other factors also at play, and that's why you don't get seizures each time there is a shift in the brain state. So we come to this concept called neuronal homeostasis. This is a process by which neurons regulate their excitability. So let us assume there is an insult to the brain in the form of a traumatic brain injury, cerebrovascular accident, infections, or it could be a progressive neurodegeneration. You get neuronal loss, leading to loss of connectivity and network instability. The brain tries to repair it by wiring and rewiring of circuits. It tends to downregulate excitatory and upregulate inhibitory conductances. If this is successful, the patient recovers without developing epilepsy. But if this fails, then what results are excitable networks. Some of the reasons for this is excitatory axonal sprouting, loss of inhibitory neurons, loss of excitatory neurons that drive inhibitory interneurons, and you have excitable networks as a result. This network activity crosses seizure threshold, and then you have seizures and epilepsy. And this is a self-reinforcing process through what we described earlier as activity-dependent disinhibition. So one example here, let us say perinatal insult. You have alterations in ion channels and receptors. There is induction of immediate early genes. There are changes in neurotransmission, which can lead to hyperexcitable or hypoexcitable circuits. So that's why you don't get seizures with every patient with a perinatal insult. And you can get neonatal seizures because of the acute insult. So this is the acute stage. And thereafter, we have a subacute stage where the same changes and the seizures, they lead on to neuronal death, microglial activation, neurotropic factor expression, modulation of synaptic plasticity, and transcriptional changes. This then moves on to a more chronic stage where there is axonal sprouting, neurogenesis, gliosis, and then you have an epileptic network being formed. Now, this can be a straightforward process. Sometimes you need a second insult, and that's when the epileptic tendency becomes more prominent. So what we call as a two-hit hypothesis. It's much more easily described and demonstrated in animals and less so in humans. Now, what is the role of neuroinflammation? there is emerging data that epilepsy is a pro-inflammatory state. There are high levels of interleukins 1, beta, 2, 17, 6. Then there's this protein called HMGB1, TNF alpha, interferon alpha. All of these are at a higher level in patients with epilepsy. And there is a bidirectional relationship. Neuroinflammation can cause epilepsy. It can precipitate and perpetuate epilepsy. And epilepsy itself can result in persistent inflammatory changes. And this inflammatory process can be peripheral, it can be central, and it can also explain why some patients become drug refractory. And that's why in some patients, steroids actually helps in controlling the seizures. Now, coming to the genetic mechanisms in epilepsy, let's take one or two examples. For example, Dravet syndrome, a catastrophic epilepsy of childhood. We know it's caused due to a sodium channel mutation, the SCN1A mutation, but this is basically a loss of function mutation. So you have less sodium channels. Then how does a child end up having so many seizures? So the loss of sodium channels also happens in the interneurons, which are inhibitory. These are fast-firing GABAergic basket cells, interneurons, and they tend to have lesser sodium channels, so their activity is reduced. And that is why you have hyperexcitable networks and epilepsy. You have lower sodium channels even in the principal neurons, but these principal neurons are constantly inhibited by the interneurons, and this feedback mechanism is impaired in Dravet syndrome, and therefore the sodium activity changes. So there is dysregulated sodium current leading on to hyperexcitable networks and epilepsy in these children. Another good example is the mTOR pathway. This is essential for outgrowth of afferent and efferent neural processes. So if you have a mutation in the mTOR pathway, you can have excessive neuronal outgrowth and unnecessary neuronal connectivity. And this results in hyperexcitable networks and epilepsy. A similar example is the ARX gene mutation. This ARX gene, it encodes a transcription factor that is necessary for neuronal migration. So if you have a mutation, there is improper migration, especially of the interneurons. And if interneurons are not sufficiently present in the cortex, that means there is inadequate inhibition of cortical networks. So that disinhibition is what promotes epileptogenesis and seizures. So there are a lot of signals that regulate interneuron differentiation, function, migration, and mutations in many of these are associated with severe epilepsy. One word about kindling. So kindling means repeated subconvulsive stimuli resulting in electrical after discharges. So this eventually leads to a stimulation-induced clinical seizure. In some cases, it can lead to spontaneous seizures, which then becomes epilepsy, and this is mainly demonstrated in animal models. Applicability to human epilepsy is uncertain. So to conclude, epilepsy can arise due to various causes. The final common pathway is disturbance of this excitation-inhibition balance, what we call neuronal homeostasis, and this results in a self-reinforcing episodic shifts towards excitation, leading to neuronal and network excitability. And this is mediated by numerous neurotransmitters and proteins and ion channels, but primarily we need to remember GABA and glutamate. And ion conductance is mainly sodium, potassium, calcium, and chloride. And of course, there are a host of genetic factors that code for various proteins involved in this process. There is a major role for interneurons in this whole process, and there is increasing evidence of glial cell importance in epileptogenesis. Neuroinflammation is also now considered an important factor in epileptogenesis. Thank you.
After the excellent talk by Dr. Pramod about the basic principles, we understood the neurotransmitters, then the mechanisms of how the insult and it happens. I invite Dr. Rajesh Iyer, who is a consultant, senior consultant neurologist and epileptologist at Vikram Hospital, Bangalore. He is also excellent speaker and very well experienced epileptologist, who will be speaking after the Pramod on the myoclonic epilepsies.
Am I audible? Can you hear
Yes,
me?
Yes,
Yeah,
sir.
okay, all
yes,
right.
yes, sir.
Good evening to all of you. At the outset, let me thank the fine team, Dr. Shripad and Sujit, for having me here for this talk. So without wasting much time, let me go into the topic. This is myoclonic epilepsies. Uh, so what is myoclonus? Myos means muscle and clonus means quick movements. So there can be rapidly alternating contraction and relaxation, which leads to a jerking or twitching of the muscle. The term was coined by Friedrich. The symptom is a brief shock-like involuntary abrupt jerk of a muscle or a group of muscles occurring spontaneously or to certain stimuli. And there are basically two categories of myoclonus, epileptic and non-epileptic. So what is epileptic myoclonus? It occurs in a variety of epilepsies and epilepsy syndromes, and they're also known as myoclonic seizures. Now, what is the term myoclonic epilepsy? So it's a very vague definition to call something as myoclonic epilepsy, because very often there might be other seizure types also in patients who have myoclonic seizures. So in myoclonic epilepsy, myoclonic jerks are the prominent seizure types in an otherwise epileptic disorder. And there may be other seizure types or other neurological symptoms. For example, somebody has progressive myoclonic epilepsy, they may have other cognitive issues and other deficits. Now, coming to non-epileptic myoclonus, it is very important to distinguish this from epileptic myoclonus, and it happens with so many conditions. You would have seen patients with hepatic failure having negative myoclonus, and then action myoclonus in patients with progressive myoclonic ataxia. Then physiological, you all know, sleep myoclonus or hypnagogic jerks, hiccups or single tusk is a very common example. And various neurodegenerative disorders can have various kinds of myoclonus, certain storage disorders, infections, toxins, various drugs, and of course, physiological, I already mentioned. Now, what are the clinical features of epileptic myoclonic jerks? So you need to make a diagnosis primarily based on somebody's symptoms. So as I said, it may be the only manifestation of a disease, for example, in benign myoclonic epilepsy of infancy, or it could be part of a disease like JME or progressive myoclonic epilepsy. Typically, the jerks last for 1 to 2 seconds, and it can be generalized where the whole body is involved, or it could be focal, multifocal, or segmental. And typically, it affects the upper limb, neck, and head regions. They are very often triggered in the mornings after sleep, and sleep deprivation triggers myoclonus. The symptoms that patients describe would be like, dropping a glass of water or tea from their hand, or the toothbrush going towards one side, or as if somebody is pushing them. And if it affects the lower limbs, they'll feel that they fall down if it affects the lower limbs. And sometimes myoclonus may precede a generalized tonic-clonic seizure. And typically consciousness is preserved in myoclonus, except in myoclonus status, or when it happens in clusters, or in myoclonic absences. Now, what is the differential diagnosis of myoclonic seizures from the symptom perspective? I said negative myoclonus, hyperexplexia or startles due to various reasons can mimic myoclonic seizures, hypnagogic jerks. Very often patients come and tell us that, at night they got a jerk and they're scared. And particularly if people have epilepsy, they report it more often. Action myoclonus of various PMA syndromes and movement disorders. For example, chorea, tics, and tremors. Sometimes it becomes quite difficult to distinguish tics and tremors. Of course, epileptic spasms, if they're very brief, might mimic myoclonic seizures. Now, how do you make a diagnosis of myoclonic seizures? The diagnosis is electroclinical. That is, you have a clinical feature or a clinical description of the event along with an EEG correlate. MRI is typically normal in most of the myoclonic epilepsy syndromes, and in degenerative epilepsies or degenerative myoclonic syndromes, you may get brain atrophy. And of course, genetics might help in making diagnosis of some of those myoclonic epilepsy syndromes like Dravet syndrome, which Pramod was mentioning. Now, let us see how a seizure looks like. It's always better to see something than listen to the theory. So this is how a typical myoclonus would look like. A brief jerk of the upper part. You can see the head and the upper limbs as well. And if it is more severe, the whole body can be affected. It can be singular or repetitive. And this is the typical EEG of a myoclonic seizure. Sometimes the ictal and interictal EEG might be similar. And for all these spikes that you see, there may not be a clinical correlate. So the typical EEG abnormality is a generalized spike, polyspike and wave discharge. This is what you see, polyspikes followed by a polyspike and a wave discharge. This is the classical EEG finding in a myoclonic epilepsy. Now, how do we classify myoclonic epilepsies? This is from the exam perspective. You can classify it based on the age of onset as those epilepsies which start in infancy, those which start in early childhood, and then in adolescence. And you can classify it based on the pathophysiological mechanism as cortical. Again, cortical can be either spontaneous cortical or cortical reflex myoclonus, where the myoclonus is triggered by various kinds of reflexes. And then epilepsia partialis continua, which I think Kalyani will delve upon. And then there's a thalamocortical type of myoclonus. This is the commonest ones that we see. For example, in juvenile myoclonic epilepsy, there's a thalamocortical network which triggers the myoclonus. And there's something called a reticular reflex myoclonus, which again is part of idiopathic generalized epilepsy syndromes and epileptic negative myoclonus. So the cortical myoclonus is something quite interesting. This is basically because of hyperexcitable sensory motor cortex. Therefore, it's often triggered by stimuli and it's known as cortical reflex myoclonus. And these are typically distal and very brief. And it's also known as fragmented epileptic convulsion. And interestingly, the EEG may not show anything during these spikes. I showed you the example of a myoclonic EEG that was in a typical myoclonic epilepsy syndrome. Whereas in many of these cortical reflex myoclonus, you may not find anything on the EEG. There may be spikes, but not correlating with the EEG. So they are, because they are very small in amplitude. And when, in neurology, when you find small amplitude potentials, you do something called averaging so that you get more and more potentials at the given time frame. And that leads to a better demonstration of the spike of the potentials. So there's something called jerk locked back averaging, which is done to see if there is if the myoclonus is because of an epileptic etiology or not. But most often you may not require, because many patients will have other type of seizures, and the EEG may very often show other spikes in the routine EEG. And many of these cortical reflex myoclonus are associated with giant sensory evoked potentials in the because of hyperexcitable sensory motor cortex, and is typical of very many of the progressive myoclonic epilepsy syndromes. So the other type is the thalamocortical one, which is the commonest type of myoclonus you see. It can be axial and it's bilateral and involves the facial muscles also. The EEG shows typical generalized spike, polyspike and wave discharges with a normal background activity. Reticular reflex myoclonus, the origin is in the lower part of the brainstem. Again, it's some people believe that it's part of the thalamocortical excitation pathway. And then the epileptic negative myoclonus is a very rare phenomenon where there is sudden loss of muscular activity. So negative myoclonus need not always be metabolic. It can be because of epileptic reasons as well. Now, coming to some of those myoclonic epilepsy syndromes, in infancy, you got mainly this early myoclonic encephalopathy syndrome, which is a very catastrophic and rare epilepsy, and most children don't survive beyond a year, and it can be because of several causes like inborn errors of metabolism. The other type is a benign myoclonic epilepsy of infancy, which starts between 6 to 3 years. Here, myoclonus is the only manifestation. There might be a family history and generally responds very well to treatment and is self-limiting. Dravet syndrome is something which is very important because it is not as rare as it was previously thought of. Typically, the children are normal at birth, and then they develop something called a developmental epileptic encephalopathy. And often the seizures begin with the first episode of febrile seizure. And very often the seizure might be a prolonged seizure, it might be a febrile status. And quickly they start developing polymorphic seizures, like partial epilepsy on either side, generalized tonic-clonic seizures, and later myoclonic seizures as well. And it goes through 3 typical phases. Initially, there will be febrile seizures within 12 months of age, often triggered by a vaccination. And then second is a relentlessly aggressive phase where there are frequent seizures, often triggered by fever, cognitive dysfunction, and progressive neurological deficits. They may develop other neurological problems like ataxia and pyramidal tract involvement. And later there's the static period of regression where the seizures come down, but there are permanent neurological deficits. The EEG is not diagnostic, might show generalized or focal slowing. And other differentials would be other genetic syndromes like the sodium channel 2A, PME, and the DOSA syndrome. So the diagnosis is based on clinical features where otherwise normal child develops seizures with fever and rapid regression and later develops myoclonus. And the treatment is extremely difficult. And the most important thing is to avoid drugs like lamotrigine, phenobarbital, or carbamazepine, which worsen the disease quite rapidly. Usually valproate, levetiracetam, benzodiazepines are tried. And there are specific indications of use of a drug called stiripentol as well as cannabidiol, which is recently approved for this. Ketogenic diet has also been tried. But generally treatment is very disappointing. The other seizure type is called dosa syndrome. It's not DOS, it's pronounced as dosa. We can remember idli dosa. It's slightly at a later age, 2 to 5 years of age, and often starts with generalized tonic-clonic seizures. And immediately, this phenomenology is quite interesting. You get a myoclonus, and then there's rapid loss of tone leading to fall. And about half of these patients can have a good prognosis. And some of them develop a myoclonic status, and that's called as myoclonic storm. And I'll discuss the treatment about myoclonic epilepsies together. Juvenile myoclonic epilepsy, or also known as Jan's syndrome, has a triad of 3 types of seizures. The first one to appear is absence seizure. And then myoclonic seizures appear, which typically happen in the early morning hours. And JME is the prototype for all this counseling process, the trigger factors for epilepsy and all. And generalized tonic-clonic seizures are typically characterized by initial myoclonic jerks, then a tonic-clonic phase. It's also known as myoclonic tonic-clonic seizures, and this happens in about 90% of patients, and this is the last to appear. The epilepsy syndrome starts around puberty, and seizures are typically provoked by sleep deprivation or interruption of sleep, watching video games, and various kinds of pattern like playing chess, etc. And the diagnosis is electroclinical. The EEG shows typical frontally dominant generalized spike and wave discharges, and find that the maximum amplitude of the spike is not frontopolar, but a little bit behind that in the frontal electrodes. And typically the background activity is normal. The spikes tend to be better expressed in this record immediately after sleep. And there can be fragments of the same spikes of the same frequency as well. So this is an example of a patient with JME. Just watch the seizure. So if you see one, you'll remember, sorry. Yeah, so initially she gets a few brief myoclonic jerks of both the upper limbs as well as the legs. You can see those jerks. And then she has a head adversion towards the left. So normally a head adversion gives a lateralizing value. So that's why she went into the VDJ program, because the MRI showed a right MTS and she had this kind of features. But then when we analyzed the seizure carefully, there was a myoclonic jerk at onset. And then she was put back on valproate after refractoriness to other drugs. And then she has remained seizure free. Her interictal EEG shows generalized spike and wave discharges, and the ictal EEG shows generalized spike, polyspike and wave discharges. Okay, so that is about the JME syndrome. Subsequent EEG gets spoiled by the artifacts. There are various other types of myoclonic epilepsies. There's a epilepsy which is associated with absences called epilepsy with myoclonic absences. Pretty rare. Typically, it affects the shoulder areas and it's very resistant to treatment. But otherwise, they are cognitively not that bad. There is one more syndrome called perioral myoclonia with absences, where you get jerks around the perioral regions, and then they may be associated generalized tonic-clonic seizures also. In many of these IG syndromes, absences, myoclonus in different areas are part of a larger spectrum of IG syndrome. There's a syndrome called G1 syndrome, eyelid myoclonia with absences. And reading epilepsy is also a myoclonic epilepsy syndrome, where you get, when you start reading, you start getting a jaw myoclonus. And myoclonus is also seen in Lennox-Gastaut syndrome, where it is not a generalized epilepsy. So far, I was telling that myoclonic jerks, the EEGs that we saw were all generalized. In Lennox-Gastaut, the myoclonic jerk is pretty much, it's called as a massive myoclonus, and is because of quick spread of a focal epilepsy to the contralateral side, resulting in bilateral proximal movements, axial movements, and fall. And of course, the PME syndromes. So this is one example of eyelid myoclonia. You can just see, because of certain reasons, I didn't put the full video. You can see that there is brief blinking of the eyelids. And during that time, you can find this kind of discharge in the EEG. This is a fast rhythmic spike, which is going on during the event. So this is a borderline or an outlier of IG syndrome. This is not fitting into the exact G1 syndrome. G1 syndrome has eyelid myoclonia, but the photosensitivity will be very remarkable in that. These are other types of syndromes which look like myoclonus. This is somebody who has a stimulus sensitive drop and has frequent injuries to his head. And this is another child who had Lennox-Gastaut syndrome with myoclonus as well as astatic drops. So these kind of epilepsies respond pretty well to corpus callosotomy. They don't do well with the routine medicines. Okay, so this is a cortical myoclonus. Kalyani will be talking more about that. So this is a patient who had Rasmussen encephalitis with, you can see on the tongue, it's called epilepsia partialis continua, which is affecting the tongue and her speech also. And so the best way to treat this is typically resistant to medicines. Best way would be to go and resect out that area, and that has stopped the the EPC completely. So coming to the last part of the talk, the progressive myoclonic epilepsies. This is a group of rare clinical and genetically heterogeneous disorders, and they're characterized by myoclonic jerks, generalized tonic-clonic seizures, and progressive neurological deterioration. They may have severe cognitive impairment, neuropathy, myopathy, and ataxia. The myoclonus is typically an action myoclonus, unlike the other epilepsies where it's a spontaneous myoclonus, here it's a action myoclonus. And they can have a combination of positive and negative myoclonus. And important is that if you use drugs like phenytoin, it worsens the disease. Valproate is a good drug for this kind of epilepsies, but you have to be careful because one of the differential is a mitochondrial disease where valparin can worsen it. So this is an example of a patient with progressive myoclonic epilepsy. 18-year-old boy who presented like a JME syndrome with myoclonus and GTCS, but quickly he started developing cognitive impairment and progressive neurological deficits. You can find that the action myoclonus doesn't have a EEG correlate, but in between you are finding a lot of spikes in the EEG. So this is a classical example of a PME syndrome. Genetics was negative in this patient. Very often in PME syndromes, you can't fix up the exact cause. So this is a reference which you can read later by Calvia in N. It's a good review of various causes of myoclonic epilepsy. And generally the treatment for PME is quite disgusting. So coming to the treatment of myoclonic epilepsies, very often myoclonic epilepsies are part of epilepsy syndrome, and probably you need to look holistically and treat myoclonus as one of the components. And sometimes the myoclonus may not be very disabling, and they're quite resistant also to treatment. In the IG syndromes, when there are polymorphic seizures, drugs like valproate, levetiracetam, lamotrigine, topiramate, zonisamide, and benzodiazepines, these are quite effective. Very often we use levetiracetam with the benzodiazepine, or if it is resistant, we use valproate, because valproate works for all the seizure types in IG syndromes. We need to remember that the drugs like carbamazepine, phenytoin, and gabapentin are pro-convulsive. They increase the myoclonic jerks, whereas drugs like phenobarbital increase the absence seizures in this IG syndromes. Clonazepam and other benzodiazepines have quite potent anti-myoclonic drug action. Some of this myoclonic, especially if it involves the islets and myoclonic absences, are quite resistant to treatment. Probably we need to ask patients to come to terms with their kind of problems and learn to adjust with non-drug therapies as well. PMEs are extremely difficult to treat. Of late, zonisamide and perampanel have been found a little bit effective. Of course, we need to avoid drugs like phenytoin and probably lamotrigine also. So to summarize, myoclonus can be divided into two groups, epileptic and non-epileptic. And there are various categories of epileptic myoclonic seizures. There can be benign syndromes like the JME syndromes, or benign myoclonic epilepsy of infancy, or there can be quite catastrophic epilepsies like the Dravet syndrome, and then the progressive myoclonic epilepsies. Myoclonus can also happen with various other symptomatic conditions. For example, post-hypoxic ischemic encephalopathy, myoclonus is one of the commonest manifestations and generally indicates a bad prognosis. And various other kinds of structural lesions can also lead to myoclonus. So myoclonic epilepsy, to be defined, if you want a definition for myoclonic epilepsy, you can say that it is a syndrome, or it's a group of disease characterized by myoclonus in association with epilepsy or epileptiform discharges in the EEG. That is a very basic simplified classification of myoclonic epilepsy. It can be the only symptom of a disease and more often part of a syndrome. The diagnosis is by EEG and a video EEG. It's an electroclinical diagnosis, and you need to exclude other non-epileptic myoclonus. The causes are generally IG syndromes, various genetic disorders, and it can be symptomatic causes as well. And you need to keep in mind that drugs like the sodium channel drugs like phenytoin, carbamazepine, as well as gabapentin can be pro-convulsive in these instances. Before I conclude, I'll just put a couple of questions which is not there in the initial presentation. So one is cannabidiol is useful in which of the following epilepsies? So one is Dravet syndrome and LGS. Next one is Dusa syndrome, West syndrome, and refractory JME. If we get time, we'll discuss it at the end of the talk. So the question is, where is cannabidiol useful and whether it is approved or not? And the next question is, all are true except myoclonic seizure is a generalized seizure but can also occur in rapid secondary generalization. Drugs like carbamazepine, phenytoin, and gabapentin can worsen myoclonic seizures. Lamotrigine and carbamazepine are contraindicated in Dravet syndrome. Negative myoclonus is not epileptic in origin, and EEG of myoclonic seizures in IgE is characterized by normal background, frontally dominant generalized spikes, polyspikes, and wave discharges. So these are two questions. They're very simple questions. If you have listened to the talk, I'm sure you would have got the answer. So with that, I conclude my talk. Thanks for your kind attention.
So thank you, Dr. Rajesh, for an excellent talk and reviewing all the myoclonic epilepsy, which is very big topic. I invite today's third speaker, Dr. Kalyani Karkare, to speak on Rasmussen's encephalitis. She's all three speakers today are from Bangalore. She is working in Sagar Brain and Spine Hospital, a consultant neurologist and epileptologist. She has done her DM from Nimans and then fellowship from Chitra. She is a gold medalist from during her while passing out. So I invite Kalyani for her talk.
Thank you. Thank you, Dr. Sujit. Thank you, everyone. After two excellent talks, here I am to present about Rasmussen's encephalitis. We have been told that basically these talks are aimed at towards the exam preparation. So I have made it crisp and up to the point. So as we all know, the topic is probably so much extensive that you won't be able to cover it in 15 minutes slot. These are the headings under which I would be presenting them. So basically, Rasmussen's encephalitis was described by American neurologist Theodore Brown Rasmussen in 1958. And before him, around 50 years before, it was by Kovenikov from Russia. They both have described a focal chronic encephalitis leading to unilateral focal seizures. It's a very rare neurological disorder and so rare that in an established epilepsy center, sometimes you may be able to see 1 or 2 cases in a year. So a rare neurological disorder, the important features are there is a unilateral inflammation of the cerebral cortex. They have a drug-resistant epilepsy eventually, and they would have progressive neurological and cognitive deterioration. So coming to the clinical features, the first part is seizures. So generally, how would the patient present to us? So it would be a child, average age of around 6 years, but there are reports where Rasmussen's has come at an adult age and sometimes at a very early age. And they would not have any antecedents in the form of febrile seizures or status or any developmental delay. An apparently normal child would come with a sudden onset of focal seizures, which are generally focal aware seizures. So they would start with somatosensory seizures, or they would have something characteristic, which Dr. Rajesh sir mentioned before, is epilepsia partialis continua. So what does that mean? It's an epilepsy which is involving partialis, that is a part of a body, and it is continuous. That means it may last for 1 hour and it would be recurring at intervals. Like sometimes they may stop, but within 10 seconds they recur again. So that is when we say epilepsia partialis continua. So this time the patient is conscious and it is affecting only a part of a limb. But this is not the only presentation of seizures. Sometimes patients may have focal seizures with impaired awareness. That means originally we used to know as complex partial seizures. They can have recurrent generalized seizures and sometimes they may present with status. As he has shown that wonderful video of the lingual epilepsia partialis continua, that means the repeated jerks limited only to the tongue, resulting in dysarthria. This was a paper published by Chitra. Sometimes patients can have postural seizures. That means seizures would result into the loss of posture. So what are the main clinical features? They go through 3 stages. So Rasmussen's may present to us through prodromal stage, evolving into acute stage, and then finally landing into a residual stage. The mean duration of the prodromal stage is around 7 months, but sometimes patients may directly land into acute stage. What do we mean by prodromal? That means patients would start having few infrequent seizures, and on careful examination, we may find that there is a deficit from one to other side in the form of mild hemiplegia. Whereas when they land to an acute or progress to an acute stage, the seizures become more and more frequent, especially the epilepsy partialis continua, and they start having cortical deficits, which are unilateral, that is contralateral to the affected hemisphere, which may be either hemiparesis, hemianopia, cognitive deterioration, and if dominant hemisphere gets involved, then aphasia. In residual stage, that means as the disease progresses, with the treatment or otherwise naturally, the seizures reduce, but the neurological deficits remain permanent, and the seizures may continue, but that won't remain as the main concern for the patients. What kind of cortical deficit? So as I highlighted before, that it is hemiparesis, which is easy to see even in a non-ictal period. It is also important to know that if we see a patient into immediate post-ictal period, we have to differentiate it from the TONS paresis. But in a non-ictal period, we would still see that there is either a difference in the dexterity, or in severe cases, we can see a frank hemiparesis. Though this disease affects MRI-wise the caudate and the putamen, somehow movement disorders are less common, but rarely we can see hemidystonia and hemiepilepsy. In cases where there is not much of epilepsy partialis continua or not much of motor seizures, and they are presenting more like temporal-like semiology, a neuropsychological assessment done periodically will show us the cognitive deficits more as compared to the standard deficits. So, in summary, how would a patient present to us? It would be a young child with no antecedents, initially low frequency seizures with mild deficit that would progressively increase to higher frequency of worsening cortical deficits, and then the deficits would remain fixed with reduced seizures. And though epilepsy partialis continua is a known feature and is a very famous feature about Rasmussen's, it may be present in only 50% of them. The range is around 56 to 92%. So there is a huge range for having epilepsy partialis continua. How do we proceed in this patient? So of course, the commonest investigation what we will do is EEG. What EEG would show is unilateral hemispheric background dysfunction. That means the hemisphere would show slower background as compared to the opposite hemisphere. There would be intrictal discharges, but within a hemisphere, there may be multiple foci. That means you may see a frontocentral or a posterior or centrotemporal or frontotemporal. So within a hemisphere, multifocal discharges will be seen. Sometimes these discharges may be bilateral. That doesn't mean that the disease is bilateral. The disease affects one hemisphere, but the epileptogenicity may be more widespread. Other thing is, if the disease has progressed and the hemisphere has atrophied due to neuronal loss, sometimes we may even see false lateralizing. That means if the right hemisphere is involved, rather than seeing the right-sided discharges, we may see them reflected onto the left side. One more important thing is, even if epilepsy partialis continua looks so dramatic, the ictal onset may not be correlated. That means you may not see any ictal correlate for epilepsy partialis continua, but that doesn't make it non-epileptic. And the EEG may be useful as we see the disease evolution, because we see that the background becomes slower. Ultimately, the EEG changes may be seen bilaterally, and there would be the loss of physiological rhythms as the disease progresses. So for example, in this EEG, the first three channels are of the left side, the fourth and fifth, and from the bottom, the last three. These represent the right hemisphere. And as we could see that as compared to left, the right hemisphere is slower. And we could see these multiple discharges which are occurring pseudo-periodically into the frontal and the temporal region. So there may be multifocal discharges, there may be periodic discharges, and there would be background slow. Coming to the radiology, CT is not the choice of investigation, but in a later stage would show us, like for example here, as compared to the right side, the left side, the sulci are more prominent. They are more prominent in the peri-insular region, and there is ipsilateral ventricular dilatation, which is ex vacuo dilatation. So the ideal modality of choice, of course, is MRI. So the MRI changes can be very gross or they may be very subtle. So the image on the up, that is the image A, is what is showing us serial interval. That means once the MRI was done in the earlier part of a disease and then it is repeated, what does it show us? That the right hemisphere has atrophied predominantly into the pericilium region or the peri-insular region with associated dilatation of the ventricles. Whereas sometimes the changes may be so subtle, that is the down figure. So we progress from left to right and we see that there is a sulcal prominence again near the peri-insular region, but also overall the right hemisphere over time, and it may be very subtle. So unless we compare the current MRI with the previous one, it would be difficult to see that it is progressing. So the hemispheric cortical atrophy progression is what happens into this disease. But before that, what happens is signal intensity changes. That means when the disease in its acute stage. So when there are many seizures happening, what we see are the hyperintensity signal changes, which are seen into the white matter, into the peri-insular cortex, as well as into the cortex, and in some cases, even into the putamen. Here, though it is considered to be an inflammatory disorder, hardly there would be a contrast enhancement. And what is more important is serial imaging would clinch the diagnosis. It is said that in the affected hemisphere in a year, around 29.9, so around 30 centimeter cube volume loss would be seen as compared to the unaffected hemisphere. This MRI has been staged as a BN staging, that is from stage 0 to stage 4, depending upon increasing worsening of the problem. So stage 0, when there is no abnormality, that means the patient comes to us seizing, but an MRI is not showing any abnormality. This can happen, so the median interval between seizure onset and the MRI changes can be 15 months, and it may range from 1 to 80 months. Stage 1 would show hyperintense signal changes and swelling, and the duration may be again from few months to a year. Stage 2 would be the hyperintense signal changes with a normal brain volume. So now the swelling has reduced. The ictal changes have disappeared, the swelling has reduced, but the hyperintensity remains. As we progress to stage 3, the hyperintensity signals may remain, but the atrophy sets in. And finally, the signals would become normal. These are the signals which we are talking about, T1 and T2 hyperintensities, and progression of atrophy is what would happen into the. So this is concomitant with the pathology which is happening in these cases. Apart from these tests, the less done tests are PET, SPECT, because these tests may show the picture similar to MRI, or in some cases, when we have a clinically high suspicion of Rasmussen's, but MRI is not showing changes, the PET and SPECT may show earlier changes. That means hypometabolism into that hemisphere in the peri-insular region, or hypoperfusion in case of SPECT. Or if the patient is seizing actively, then there would be a ictal PET. That means there would be a hypermetabolic change from the area where it is seizing. For example, in case of lingual EPCs, if it is the opercular region which is seizing all the time, then we would see it as a hyper PET or a hyper SPECT. CSF can be done in these cases, it is done routinely, but it would either show non-specific changes in the form of high protein, or it may show increased oligoclonal bands. Into the pathophysiology, it was believed initially that probably the antibodies against the glutamate receptor 3 are the ones which are responsible for this disease, and hence in some patients serum GLUR3 antibodies were done. They were seen to be raised, but that is not true for all the patients. Ultimately, the diagnosis can achieve by brain biopsy, but it is rarely required because the clinical, the radiological and EEG picture is very characteristic. But if it is done, then it is done from a non-eloquent area, especially where the signal changes or where the PET and SPECT changes are seen. And what we need to remember that this disease may be patchy, and hence a biopsy can miss the findings or can be non-specific. It also depends upon in which stage we are doing the biopsy. So that would change how the picture would be. So it would show either an inflammatory change or a change of complete neuronal loss. So if we combine all these clinical EEG and MRI pictures, there are this European consensus criteria for diagnosis of Rasmussen's, which has part A and part B. So either you can have part A or part B, and part A should have all the three features, and part B can have two of the three features. So clinically, a patient would have a focal seizure, which may be epilepsy partialis continua, but may not be. And they would have unilateral cortical deficits. That's a clinical feature. EEG, as I said, unilateral slowing would be there. There may or may not be epileptiform discharges. And if you get a seizure, it will be a unilateral onset. And in an MRI, you will see a unihemispheric focal cortical atrophy with or without signal changes into one of these, like either a gray or white matter or in the caudate, ipsilateral caudate. If we see part B, we additionally may need additionally a histopathological change. So I'll come to the histopathology basically. This I've highlighted the part A and part B for us to see that basically it's a T cell dominated encephalitis. So what do we see pathology in this? So in the early stage, when there is inflammation, when the patient is in acute stage, when the patient is seizing and the MRI is showing hyperintense signal changes, what we see on the HNE stain is basically around the vessels, there would be a dense lymphocytic infiltrate. There would be a reactive genostocytic proliferation. And what we would see is microglial nodules. If we go, so these microglial nodules, when stained through an HLA-DR stain, this is the way they would be seen as a clump of microglia. And if we zoom them further, what is seen basically is those grayish structures are the neurons, and near that the brownish things are the granules. So what we can see is these microglial nodules, the microglia, they would have their granules or the cytotoxic granules which are directed towards the neuron. And then they would dissolve the neuronal membrane, which would cause increased excitability, increased synaptic hyperexcitability, resulting into seizures. But when there is a apoptotic cell death, so these CD8 T cells, which are implicated into this, they would cause expression of MHC class 1 on the neurons, and then they would initiate a apoptosis. So in that case, there would be loss of cortical neurons. So if you take a section of the brain, you would see that there would be loss of neuronal layers. It is also seen that sometimes we may have dual pathology, like patients of focal cortical dysplasia and Rasmussen's can be existing together. Coming to the pathophysiology, so as I said, there had been many theories, like there had been many animal models where people have tried to figure out whether it is a B cell mediated, whether it is a T cell mediated, whether there is a virus which has triggered this response. So it has been seen that though all of these things, like even people have found NMDA antibodies in Rasmussen's, there is a chance that it's an inflammatory pathology. And depending upon at what stage we are analyzing it, sometimes these antibodies are found to be a part of the pathological process as an effect of it rather than the cause of it. It has been thought that why this process is unilateral, like if it is an inflammatory disorder, why it is not bilateral. So there had been hypothesis where it is considered that probably there is an unknown rare virus trigger, or on the top of it, there is an unknown migratory cell defects. On the top of it is an unregulated immune process, and that's why it is happening focally. Why is it happening near insular region largely? I actually tried to search for it and I couldn't get the answer. But it is found to be more starting in the perinsular region, less into the occipital, but there are adult onset Rasmussen's cases where we can find even occipital origin of the inflammatory process. So basically it's a CD8 T cell mediated disease which results in inflammation and ultimately apoptotic cell death and cortical or neuronal loss. What other diseases can present like this? So any unilateral hemispheric involvement in the form of a Sturge-Weber syndrome or HHE, that is hemiplegia, hemiconvulsion epilepsy syndrome, and rarely unilateral moya can have. Then there is something called Davidoff-Masson syndrome, where the unilateral cerebral involvement is associated with compensatory sinus enlargement as well as calvarial hypertrophy on the same side. But they are very characteristic. So I would say that Rasmussen's presents so characteristically that it is very difficult to miss it. Though there are there are range of cases and anecdotal reports where patient would have presented just with the progressive cortical deficits, but no seizures for many years. So there are rare presentations of Rasmussen's, but generally it is a very characteristic presentation. Coming to the treatment. So when we are in the phase of the disease, it depends upon, first initially it's just few seizures. So using antiepileptics is going to take care of those seizures. But as the acute stage comes up and the inflammation is the one which is the important thing to consider, there comes the role of immunomodulators like steroids and other therapies. And then ultimately, when the residual stage happens, then there is hardly any role of any of these modalities. So commonly, what are the goals is we want to reduce the inflammation, we want to control the seizures, and we, if possible, reverse the functional deficits. So of course, seizures can be controlled by anti-epileptic drugs. We can choose the drugs according to, because most likely they are focal seizures, we can choose the drugs which work best with the focal epilepsy. For inflammation, we can use steroids, IVIG, even people have used plasmapheresis, tacrolimus, rituximab, as well as interferon. But being a T cell pathology, interferon works less. But a final treatment in this disease is surgical. Why? Because this is a progressive unilateral hemispheric disease and it progresses relentlessly, and there are very few examples. For example, Dr. Rajesh had shown before that if there is a lingual EPC that limited only to the tongue, and there is a hyperintense signal change on the MRI limited to the fronto-opercular region, then just a focal resection of that would result in removing those seizures. But there is a chance that over time, new foci into the same hemisphere may develop, and ultimately patient has to go undergo functional hemispherotomy or hemispherectomy. Counseling for the deficits post-op need to be explained. Surgery in Rasmussen's is a separate topic because it depends upon the timing of the surgery. Like, when do you want to do surgery? When are we expecting the shifting of the language function from one to other hemisphere? So that has a whole detail, but what we need to remember is the most effective treatment in Rasmussen's is surgery. There have been candidate treatments which have been tried apart from the standard immunomodulators, but most of them have not been proven useful in Rasmussen's. I had been told that I should tell about some references. So this is just a part of the references, but I would say that these are very useful, very comprehensive articles which open up what's so nice with Rasmussen's. Like, you can get into these articles and then go to the cross references, but these are probably the must for reading for Rasmussen's encephalitis. Thank you.
So after the extensive coverage of the Rasmussen's encephalitis in detail, we move towards the last lecture of today's talk, today's module, about the evaluation of a case of medically refractory epilepsy. So previous three speakers has covered most of the parts about what is the pathogenesis, then how we should evaluate. So I will be summarizing them in my talk. So it will be, the outline of the talk is like definition, then I will be speaking about some surgically remedial syndromes, then what is meaning of pre-surgical evaluation, what are the modalities of evaluation, and finally algorithm. So this was a landmark paper in 2000 in NEJM by Kwan and Brody about the probability of seizure freedom in a newly diagnosed epilepsy. When we give first one drug, there are 47% of the patients were seizure free. With the second drug, 64%, and with the added drugs regimes, there are very few patients were the seizure free. That is the third drug. When we add, it is the 3% of the patients were seizure free. Now it has been found that over the years that there may be some difficulties, different analysis, and with the third drugs, if you compare the same population who received third drug, there may be more than 14-15% of the patients are seizure free. So what is the natural history of a treated epilepsy? If we go, 64% are seizure free and 36% are not controlled, and out of this 30% become refractory. So what is the definition of drug-resistant epilepsy or medically refractory epilepsy is, this was defined by Eileen to 2010 that failure of adequate trials of two tolerated and appropriately chosen used anti-seizure drug schedules, either as a monotherapies or in a combination to achieve a sustained seizure freedom. As we saw in the previous talks, appropriate drugs means those drugs we should not aggravate this epilepsy syndrome. So we have to treat choose the drug appropriately according to epilepsy type, according to epilepsy syndrome. And what is the definition of a sustained seizure freedom? That means they should be free of seizures for a minimum period of 12 months or a period of 3 times the previous longest seizure-free period, whichever is the longer. Means somebody has a seizure 1 per year, he should be seizure free for 3 years, or 6 months, he should be seizure free for at least 18 months. So this was a simple rule which we apply for medically refractory epilepsy. That is a rule of 2, that the number of seizures for more than 2 months, for more than 2 years, and 2 appropriate drugs. This is more we use in adult population, but in pediatric population, as it is a developing brain, we should not be waiting for 2 years, and we should wait maximum for 1 year. So what are the early identification markers for the refractory epilepsy or factors associated with refractoriness? The most important are failure of 2 appropriate antiepileptic drugs, and the etiology is like mesial temporal sclerosis or focal-cortical dysplasia. Such patients are unlikely to respond to antiepileptic drugs, and what we call them as a surgically remediable syndrome. Which of the surgical remediable syndromes is the most commonly is mesial temporal sclerosis with temporal epilepsy with hippocampal sclerosis. Then there are focal potential epileptogenic lesions like benign neoplasms, DNET, and ganglioglioma. Then malformation of cortical development, focal cortical dysplasias, vascular malformations, atrophic scars. Then large unihemispheric epileptogenic lesions like we saw Rasmussen's encephalitis, HHE, Sturge-Weber syndrome, and hemimegalencephaly also. And last but not least, like epileptic encephalopathies and multifocal disease, which we saw one of the case which became free of drop attacks like LGS. So these are the substrates which are the surgically remediable that we can see as hippocampal sclerosis. Here there is focal cortical dysplasia. This is a DNET. Then if you see carefully, because it requires very careful analysis, in this there is only single nodular heterotropia. While if you look this MRI at a long, immediately it looks like normal, but if you look carefully, there is a right-sided hypothalamic hamartoma, and this is a ganglioglioma. So imaging plays a major role. So what are the points or parts, how we go for the pre-surgical evaluation? For the localization, most important is history. We start with the history of epilepsy, age of onset of epilepsy, what are the seizure types, whether there are any preceding factor of febrile seizures, or there is encephalitis, or there is any trauma. Then we go for the MRI is the most important thing, but for seizure localization or the epilepsy syndrome subclassification, sublobar localization, video EEG helps for detailed semological analysis. Then may require SPECT or PET, then novel MRI techniques beyond your routine MRIs, and then last but not least is the intracranial monitoring. If it is, we feel there is eloquent cortex is involved, or there is in MRI negative epilepsy. Another important point to minimizing the deficits, because it is a functional surgery and it is not like a tumor surgery or it is not a trauma surgery. We may require functional imaging, we may require DTI, functional mapping, and sometimes to understand the network, resting fMRI. In addition, we require the evaluation of disability, where neuropsychology plays a major role, whether the patient has deficits or after surgery, you are going to give him new deficits, language evaluation as well as the speech evaluation, and last but not least is occupational therapy. So there are an array of modalities in pre-surgical evaluation. We usually start with the scalp EEG. For some of the epilepsies, scalp EEG is sufficient, but most of the time we prefer video EEG and if required intracranial EEG, which can be stereo EEG or invasive monitoring. like subdural strips. Then we require structural volumetric MRIs, other like DTI, perfusion and functional MRI, PET scan and the SPECT, and sometimes we may require MEG. So what we look when we do the evaluation, we look at the epileptogenic zone, which was a concept put forward by the Luders, and they said removal of this makes the patient seizure free. Then this surrounding area is the ictal onset zone, which we capture on the video EEG, from where we see that there is an origin or there is an onset of a seizure, and the surrounding area is like a irritative zone where we see the interictal spikes. So the epileptogenic zone is a smaller, ictal onset zone is little bit bigger, and irritative zone is a wider. This slide summarizes all the concepts, and this is the most important slide of the today's talk, where we see there is a structural lesion which is responsible for the epilepsy on MRI. Then there is a high frequency oscillation zone that is called as HFO zone, which we record during the either stereo EEG or intraoperative recording, that is electrocorticography. Then there is an irritative zone, that what I said, it is related to the interictal discharges. Then this is a seizure onset zone, or what we call it is a ictal onset zone. And now we have moved from the lesion to the network, epilepsy network. This whole area is a ictal network zone. And there is an interplay between the disease and the healthy tissue. This is the only diseased tissue where there are the dysmorphic neurons are there. They play continuously with the normal healthy neurons and neuronal circuits. And most of the time they are suppressed, and only during the seizure activation, there is loss of this suppression. And then we see there is a generation of a seizure and the manifestations in the various form of simulology. This slide tells us about the various surgical strategies, like we can remove only the structural lesion, or we can remove the structural lesion with high frequency oscillation zone, or sometimes we cover part of the irritative zone, or we can remove the seizure onset zone, or we can just disconnect this area from the ictal network, and where the patient may become seizure free. These are the various modalities which we can diagnose the various zones. Like with MRI, we identify the epileptogenic lesion. Then ECOG or HFO, we identify the HFO zone. Then there is a MEG, PET, SPECT, which tells all tell about the ictal onset zone. And then we record with the ictal EEG, we see again the seizure onset zone or the EEG zone, ictal onset zone, and the EEG spikes, which tells us about the irritative zone. And this slide, which tells now further advances about the multimodal imaging, and we see this is the MRI, which is showing this is 7 Tesla MRI, which is showing right temporal lesion. If you look at the PET, there is a PET hypometabolism. Then the EEG spikes are localized here, and then there is a EEG MEG ripples. So in these patients, MEG also shows that there is a cluster of the spikes here. Then this is a glass replica where they have identified this is a PET hypometabolism. This is a EEG onset zone, which is always bigger than the MRI lesion. Then there are the EEG spikes, which are the widespread, and then there will be the MEG ripples and the EEG ripples. And this is the final sketch where they have removed this, resected this area, which covers, there is an involvement of the MRI zone. Then there is ECOG spikes there we have removed. Then ECOG fast ripples has been removed, as well as the EEG spread zone has also been removed. So always we remove larger area than the only MRI zone, but most of the time we identify it with the help of ECOG. So moving forward to the PET, because you may get short notes on the PET, MEG and SPECT. I have covered them in only one slide, so you can go and read further. So PET tells about the cortical metabolism, and it measures the function of neuronal receptor transporters and other molecules. Most commonly used is 18-FDG PET, but also we use 11-C-flumazenil PET, which targets the GABA-A central benzodiazepine receptor complex. In tuberous sclerosis, there is a 11-C-methyltryptophan PET, that is a AMT PET, has been shown to be useful to distinguish between the epileptogenic tuber from the non-epileptogenic tubers. And then further application of MRI-based gray matter segmentation to the evaluation of PET scan doubles the sensitivity for detection of the seizure onset zone found with the invasive EEG. These are the scanners which produce 3D images of a gamma rays from the radioisotope. Most commonly used is 99MTC HMPAO. We do the specs during interictal phase and directly after the seizure onset zone. And then there is a computer-aided subtraction ictal spec co-register to the MRI that is called as SysCom, renders twice as many localized area of hyperperfusion as does visual comparison. SPECT is useful in non-lesional when we have MRI negative epilepsy or extratemporal epilepsy, where we want to map the spread and identify areas which we want to remove or to further localize the lesion. Ictal SPECT hyperperfusion occurs in both the ictal onset zone and the regions connected to this zone. SPECT findings need to be considered not in the isolation, but with the lights of the results from the EEG, MRI, and the PET, and it rather than serving as a single measure for the epileptogenic area. So we have to take all in account and not only a single investigation together during the pre-surgical evaluation. Coming to MEC, MEC is a magnetic source estimation, and it samples the magnetic correlates of electrical brain activity. It is our EEG is attenuated by the conductance of the skull, and there may be many artifacts, but that is removed by the artifacts are removed by the MEG, and it currently requires sensor cooling, which incurs the high cost and limits the flexibility of the recordings. In India, we have only 2 MEG centers, and the high number of MEG sensors in the helmet, usually more than 250, renders visual analysis of the channels as we do in the EEG is impractical, but it provides opportunities for accurate source estimation, and this right diagram shows how there are the various source estimation has been done. The MEG interictal spike cluster modeling is useful to delineate a resection. Again, MEG is predominantly used when there is a non-lesional epilepsy or we don't know the complete area or epileptogenic zone, and the removal of tissue with tight MEG spikes clusters, if concordant with the invasive EEG, associated with good post-surgical outcomes. This is a now further advanced technique of stereo EEG, although it was introduced in 1960s by Tallerich and Bancoud et al. Initially it was a frame-based coordinate electrode placement, but now it is a frameless, and more it is becoming robotic guided, so that there is a very good precision regarding the entry and target points of the placed electrodes. It has stereo EEG has more advantage rather than the invasive subdural strip electrodes, and it is gaining popularity due to lower complication rates and patient burden compared with the grid placement. Depth electrodes can also be used intraoperatively, either placed in combination with ECOG grid or in patients with tuberous sclerosis using several separate electrodes to reveal the epileptogenic tubers. So this is the slide which summarizes nearly all the points till now I covered. So we start with the non-invasive, then we go to the invasive, and then we move towards the intraoperative recording. When we want to test the function, we do the task-based fMRI, we do the DTI to know the tracks and whether we are going to view patient functional deficits. Then there are the functional TCDs, then there is a task-based MEC, and then there is a TMS. For the language, as we saw in the Rasmussen's also, for language lateralization, we use WADA. Then there is an electrical stimulation, either it is invasive with the stereo EEG or it is during the intraoperative. Coming to the epileptic focus and network identification, functional clues we get by the semology during the video EEG, and then there will be neurological and neuropsychological testing. Again, they will tell where it is the right hemisphere, left hemisphere, and further sublobar lateralization. And also we can induce the seizure during electrical stimulation during the invasive monitoring, either with the grid or with the stereo EEG. When we look at the electricity, we have video EEG, we have MEG, we have EEG MRI, and we have TMS and EEG. Then we have stereo EEG, and during the intraoperative, we have ECOG. Coming to know the structure, we have structural MRI, then high field MRI, DTI, then resting MRI, fMRI. ASL is like we have a poor man's PET, and then we also have MR spectroscopy. And we study the metabolism with the PET and the SPECT. So this is the slide which tells us about the non-invasive, invasive, intraoperative, and how we go from functional to epileptic focus and network. So this table tells when it is a unifocal electroclinical syndrome, there is a single lesion, directed resection or laser ablation. When it is unifocal, may or may not do the PET. If it's unilateral, go directly for the, again, lesionectomy or laser ablation. Whenever there is a doubt, whenever there are the two hypotheses, then only we go for the SEEG or long-term ECOG. Either when there are multifocal lesions or it is a non-localizing MR negative epilepsy, then only we go for the either stereo EEG and then 7 Tesla MRI, PET, SPECT, MR PET fusion, then electrical source imaging and MEG, and then EEG fMRI. So video EEG monitoring confirms focal epilepsy and it leads to a localizing and lateralizing hypothesis. And MRI is done and analyzed to further we have resection and what type of it. So in a presurgical evaluation, focal epilepsy, video EEG monitoring, MRI, lesion identified, complete resection of the lesion, or intraoperative electrocorticographic evaluation, mainly for functional mapping. If there is a no lesion, we do the further test and invasive evaluation based on the network hypothesis. So what are the type of epilepsy surgeries we have? Either curative or palliative. Palliatives are callosotomy, then subpile transections and vagal nerve stimulation, while the curative either focal resection or we have major resections like hemispherectomy or multilobar resection. So this is the last slide about the comprehensive epilepsy care. That is, it is a teamwork. Patient with refractory epilepsy, he required neurologist, neuroradiologist, neurosurgeon, social worker, psychiatrist, and psychologist, as well as occupational therapist. So pre-surgical evaluation, clinical, then followed by scalp EEG, then MRI, neuropsychological evaluation, video EEG, functional imaging, and then may or may not invasive intracranial monitoring. The success of epilepsy surgery depends upon the accuracy of localization and completeness of resection of an epileptogenic zone. Thank you. So now if till now there are no questions in question answer session.
There were a couple I already answered.
Okay, yes, that's good because we are reaching to our time limit of 10 o'clock.
Yeah. Good. I think it was quite exhaustive coverage of tough topics. Good.
Yes, all like starting from basic, then like myoclonic epilepsy, then moving to Rasmussen's and pre-surgical evaluation.
Well conceived. I think all these are short notes in exams.
Yes. Kaul sir is there. Kaul sir has any comments or any this?
Sir is the seasoned examiner.
Yes, that's why. Okay. So I think there are no questions. So on the behalf of Fine, again, I thank all of three because you took special time. And this is like our different, not like usual routine presentations. We have to modify according to the question answer. So it was very pleasure to have you all three and excellent talks. I think we will stop the meeting.
Thank you.
Thank you.
Thank you
Thank
so
you.
much.
Bye.
Thank
Stay
you all.
safe. Bye.
Bye.